Alright, so let's go over renal and urologic disorders. So I'm gonna kind of go through with on their slides as well, and in addition to what I got. So it was at least a combination for you. We'll just knock it out because talking points for what I've got on this one's only like 2 pages. Well, the rest of them has been like 4 to 5, so it won't take as long. That, and I kind of stuck with what the major points for each one were versus having to go into detail on the anatomy and all that loveliness again. So, because I've already went through all that. Now, of course, endocrine, as you could tell, I went through a little bit more because it does have a lot more information. So, all right. Alright, so the renal system basically, for urine formation, essentially it takes steps in 3 different stages. You've got your glomerular filtration, your tubular reabsorption, and your tubular secretion is the big things as far as looking at that. It basically does what it is, and what it says as far as the reabsorption, kind of pulling that in. And as far as the filtration, basically kidneys, blood vessels, filter the blood through the system, and then of course the reabsorption, basically for it to be filtered again. And then of course the secretion basically is getting it excreted out. So the main things of what we'll be covering, of course, is your kidneys, your ureters, your bladder. Basically that involves basically your renal system. Because we've already kind of touched bases, you can see the little adrenal gland sitting right on top of there. So we kind of know where exactly those are at. As far as the big thing, as far as assessments, the majority of what you're going to be looking at, obviously, whenever you're assessing a patient who has got a GU issue, basically just the urine color is going to be your first indicator. Obviously, burning while urination, that could be sounds like a UTI. You know, so always ask that. Of course, ever had an STD? May have come from fecal oral, you never know. So this is all kinds of stuff. You don't go fecal oral and then go to urethra oral, so you never know. Just so be mindful of that. Problems avoiding.
Remember that, guys.
Remember that.
Yeah, don't go dirty to clean, go from front to back, not back to clean, back to front. You don't do that.
God.
You don't wipe that way, let's not do nothing that way.
We don't participate that way either.
See, I mean, works out. That's why you're gonna use it. Yeah, there you go. And of course, the physical assessment itself, as far as the actual anatomy, and then of course, especially with patients, male patients who have, could be like hypospadias, could be an issue too, as far as you'll see later on. Of course, the usual diagnostic tools is basically the same. Labs, KUB, CT scan, MRI, UA, and renal. That's the big things.
What's a KUB?
Kidneys, uterus, and bladder. Basically, just essentially that lower part of the abdomen, just that suprapubic region. Some of the, that's like a patch and skin. Okay, that don't make no sense. When assessing the labs for a kidney function, as far as the labs itself, the 3 things that you want to look at specifically are what?
Creatinine, bone,
Okay.
GFR, and bone.
GFR and BUN. Yep. So if you're looking at the BUN, what is the normal BUN range?
I know it's just anything over 1.5 for creatine is bad, like it's bad.
That's correct. Okay.
Or 1.3. But
What about BUN?
over 20 is bad.
So usually about 10 to 20 is for the BUN, and for the creatinine is 0.5 to 1.2. That's your general range for both male and female. Male is usually 0.5 to 1.1, female 0.6 to 1.2. So basically 0.5 to 1.2, you've got you covered as far as the general range. And of course your GFR is another big thing that you always want to look at. As far as the actual treatment itself, of course drug therapy, just like everything else as far as certain medications. And then you've got dialysis. There's a few different forms. There's 2 different forms of dialysis: hemodialysis, peritoneal dialysis, and of course there's the CRRT, continuous renal replacement therapy, which is normally done in ICU. So hemodialysis, we'll talk about that first, regarding that particular, as far as like types of access. You have those Quintons and the perm casts and everything that you can use for that, and then that's for the temporary form of hemodialysis, because they usually have like an AV fistula, or a graft, either on the arm, on either side. So when they do those, they have to mature. So while they mature and they're healing, essentially, they'll put in that temporary cath and everything in the chest wall. So with the hemodialysis, same thing with those are usually 3 times a week. You'll either see those patients on Monday, Wednesday, Friday, or you'll see them on Tuesday, Thursday, Saturday. Or it depends on what's going on. If they have some electrolyte issues, then they may have to take them back down and just do a cleansing, not so much to pull fluid off. So there's also peritoneal dialysis. Peritoneal dialysis, like I was saying earlier, that is those particular patients are at a much higher risk for peritonitis, since that is going straight into the actual peritoneal cavity. With the peritoneal dialysis, these patients do it on their own at home for the most part. Home health, they bring out, or the pharmacy, they have their bags of fluids that's ordered per the provider. They usually put it on a machine at night, they hook it up, they go to bed, they get up, they take it off, and they drain and do all their stuff. So peritoneal dialysis that you can do, you have a lot more of the freedom of continuing to do your dailies of activities of daily living. Just live your life and go to bed and so that you're good. However, those tubes can get infected and or clogged, so of course then you have to come on into the hospital and we'll get that worked with and go over from there. But it's honestly, as far as the actual PD here, one thing that you have to remember though, when you are doing PD manually versus the machine, you know exactly how much you put in versus what you put out, and then you subtract those two, and that way you get your actual true volume that you actually put out. Because dialysis, with hemodialysis, as you can tell, you've got the 2 ports, they hook it up, and then it goes through the machine, it filters, cleans it, puts the byproduct and the waste and everything off, and then they just put the blood right back in, okay? Versus with the CRRT, same thing, same process, it's a continuous cycle. However, with it does have a heater attached to it, and with the CRRT, and the actual line as it goes back into the patient is warmed up before it gets back in, because it's going to be very cold by the time it goes through everything. So, because it pulls it out,
is that what you typically see in the ICU?
Yes.
Okay.
Yes. Yeah, that's the only place that you'll see CRRT. So, we're not doing it for by any means. And those particular patients, when you do have them, you are a one-to-one patient. That's your only patient that you're going to have. So, just because how often and that you have to check the machine, check your settings, check everything. There's so much monitoring as far as like calculations that you have to make sure and troubleshooting with the machine. And as far as like the actual dosage, as far as the bags, the meds, the electrolytes, and everything that you have to watch. So it's very time consuming. So with those patients, that is your only patient if you have that particular one. Now with hemodialysis, dialysis nurses, they'll have 2 to 3, if I'm not mistaken, here.
You have 1 nurse on the floor and 3 techs. That nurse is responsible for 12 patients.
No.
But you have a tech per pod, which is 4 patients per pod. But the nurse is the one that has to assess all 12 and give meds to all 12.
Yeah.
There's no doctor in the building.
That's almost
No,
like
never
dangerous.
That's
like,
too much. So like the outpatient clinics, yes, that's at that point they are. One, because they're a lot more stable, because they just come from home, they come in, they sit down in their chair, all right, hook me up, they just read the magazine or whatever they want to do, and
Go
then
sleep.
go
Just
sleep.
complain.
Yeah. And then
How long can someone live on dialysis?
For many years. I've had a
Yes.
patient on it for over 30 years right now.
Yep.
As long as you follow your diet.
If you follow what you're supposed to do, get your treatments, and be compliant with it, you can go for a very long time. You really can. So,
you know,
but
people
but
don't do their dialysis though.
90%.
Yeah, because they end up in
Or
the
they'll
ER.
miss a day, or they'll skip. It's like, oh, I feel fine today, And then at 11 o'clock at night, you're getting an EMS call and they're bringing Granny in because.
Short breath, fluid overload.
Yeah,
Mhm.
I can't breathe. Well, I wonder why you missed your dialysis, okay? It's all sitting in your lungs, is what it sounds like.
Mhm.
Yeah. Oh, it ain't there. So, no, that's what it is. But no, you can live a while off of those. And then you go, obviously the catheterizations, I mean, that's kind of a given as far as different things. If you have an obstruction or something like that, you're unable to avoid it, and just put in a cold catheter. Obviously, those can be temporary. Same thing with the suprapubic catheter. Those can even be temporary as far as for healing and everything. And then you get into that shock wave lithotripsy. Does really good for renal stones as far as breaking those up, and river stones, which is what we've got from the GI section. So when it comes to your hemodialysis patients, when you have a patient with a fistula out of the graft, one thing whenever you're doing your physical assessment, when you assess them, you always feel of the graft and you always listen with your stethoscope. And you'll have that bruit and thrill is what is actually as far as you'll feel the like a gushing, like a pulsating, like you'll feel it over it, and then whenever you listen to it, you hear the swishing of it. So that's the bruit and the thrill. That's basically when you know that fistula and everything is in functioning condition and it's good. Now, if you don't have either one of those, of course, you know, just let the provider and the dialysis nurse and everything know.
Send them out.
Well, they're already here.
Oh, okay, I'm like.
So, but if you're in the clinic, yeah, you can't do anything with that, so. But yeah, they're already here at this point, if you're working in the hospital, but they can go in and do a fistulogram is what it's called, and they can just basically do like a roto-rooter, clean that, you know, any extra plaque or anything like that up, so. Then you've got your, like I said, lithotripsy, that is basically to break up the calculi. And then we get into the actual surgical procedures dealing with renal. You've got your cysto and your kidney transplant, suprapubic cath, TURP, and of course urinary diversion. Your cystotomy, that's partial or total removal of the bladder, depends on what's going on. Now, the big thing with those particular patients, you have to remember, basically, you're going to have a lot of loss of sexual and or reproductive function as a result of that. So those particular patients have to go through, you know, but you know, it's hard, you know, as far as like hormones and just going through everything, especially regarding the prostate and all that. So always just be mindful of that. And then dealing with the kidney transplant, one of the big things, everyone that comes into contact with a kidney transplant after they even had their transplant and for the first week, you have to, 2 weeks, wear a mask initially right afterward because of the immunosuppression. Because those patients are going to be putting on a lot of immunosuppressed medications in order to help prevent rejection of the organ. Same thing with like a liver transplant or, you know, any type of transplant. You'll see a lot of those immunosuppressant medications just to help, hopefully, that the body doesn't reject it. A nephrectomy, it's basically a removal of the kidney itself. A unilateral nephrectomy basically just puts all the rest and everything over onto the other side. You have two of them. You can fully function on one kidney if you needed to. But basically nephrectomy that's what it is. So now, the reason for a nephrectomy could be either infection, basically just genetic, it could be different things. So you can have, basically with those, you'll either have like polyuria, anuric is actually what it is, or oliguric, because you'll see a lot of that with dialysis patients as well. Now, if you're anuric, that means no urine, you're not producing any whatsoever. And then, because you're solely based upon your dialysis and everything to filter out wild electrolytes and toxins and everything that you've got. If you're oliguric, you produce very little, I think it's less than 100 ml a day of actual urine. You're not producing much of nothing. So, and you're peeing very, very little. And it's usually in the morning from what I've seen that they'll actually pee. And then you got urinary diversion, that is basically like an ileal conduit, basically kind of a pouch in order to bring it out, like almost like a little stoma. That's where you also get into like your ostomies and stuff like that. And it's the same thing as an ostomy, but instead of instead of stool, it's going to, obviously it's urostomy, so it's going to have the urine. Now, your TURP, obviously, that's a resection bladder dealing with the prostate. Okay, we'll go into that just here in a moment. We'll go into those. So basically, your most common renal and urologic disorders, you've got acute post-streptococcal glomerular nephritis. Basically, the itis, again, that is just inflammation. Strep, it kind of tells you basically where it came from. So you've got your full name right there. Basically, it is from strep A, is usually the contributing factor. And it's bilateral inflammation of the glomeruli due to the infection. Usually, this occurs, you'll get the treatment or the onset while it cooks, essentially, as far as the incubation period. Typically 1 to 3 weeks after being untreated for pharyngitis. That's usually how you actually will get this. Penicillin, of course, is the treatment for that. Now, unless you are allergic to penicillin, then they'll go over to erythromycin for the next drug of choice. And usually with the whole pharyngitis being your contributing factor, what age group would you suspect that this would be seeing this in predominantly?
Older patients. Well, no.
For pharyngitis. 5 to 12-year-olds. So you're younger population. And then you've got acute pyelonephritis. Now this is a sudden bacterial inflammation. This is where you'll have a lot of your flank pain. And now this one will have a distinct odor with cloudy urine. You may have an idea of what kind of odor this may be.
Fishy. That's what I was gonna say, a fishy odor.
Yep, so you have a very fishy odor with this. Also with cloudy urine with the ammonia. Okay. It's a big thing with acute pyelonephritis. And then you've got acute renal failure. Now, acute renal failure, this is oliguric. This is what I was talking about is regarding the low amount of urine that you're actually producing a day. Now, their particular breath will put off a different particular kind of smell that they can actually give off. And anybody have an idea of what that may be? It's a very uremic, as they say.
Their urine?
Yeah, it'll smell like.
Oh,
their
yeah, I
urine.
mean, it's a completely distinctive smell. I
Yeah,
don't really
it smells
know.
like
It's
they
very
literally
strong, it's.
Turned up their urinal and they just drank it because that's what it smells.
So their breath smells
Their
like urine.
breath
Yeah.
will smell like
And
urine.
it's just because they've got so many toxins and stuff
Yep.
in everything.
So, no drinking from the urinal.
Mm-mm.
We'll think that you've got acute renal failure. Now, supportive measures basically with acute renal failure basically include diet, high in calorie and low in what? Low in two different things. We want to make sure with acute renal failure.
Low protein.
Low protein and what else?
Low phosphorus. I do know that one.
And what's your big one though? What electrolyte?
Potassium.
Potassium. Just because when you're not able to properly excrete that, your body will hold on to your potassium a lot more. So therefore, you're placing the patient is a lot more higher risk for cardiac dysrhythmias and cardiac issues.
Are we also on low sodium on renal patients? Or no?
It depends. It depends on what they're low and how they are actually putting up, because it actually varies on that one. But usually, you don't want to retain too much fluid anyway. So like With acute renal failure, you know, those, you usually wanna do like a 1.5, usually a 1.5 to 2 liter fluid restriction with low sodium, that way you don't retain as much. And just because we're unable to put it off, then of course you gotta limit the amount and everything too. So, but not every patient will be the same on that one though. But the big thing is avoiding NSAIDs, because it can cause more, issues with that, okay? One thing that can cause acute renal failure, that a lot of people don't put together for some reason is, rhabdo.
What?
Rhabdomyolysis. Basically, it is when you fall and you lay in one position for too long. We get these patients that come into the hospital, they've fallen at home, they were there for like 3 hours, 4 hours, and they were finally able to crawl over and pick up their phone and call 911. Those patients are rhabdo. Rhabdo is basically, it's a muscle breakdown because of where they fell and they laid in one position. Basically, it's a release of the myoglobin because of the injury into the circulatory system, therefore leading to basically that muscle tissue will go and try to get filtered out through your kidneys, just like everything does. Once it gets into the kidneys, it actually clogs up the ureters inside the kidneys. So it can cause acute tubular necrosis, which can lead to acute kidney injury, leading to acute renal failure. Because it's so clogged up, nothing can be able to filter through. So as that happens, that muscle globin, that myoglobin will actually clog it up. Your BUN will increase because your kidneys are trying to filter out, work harder to get it out there, but it's still not doing it, so it'll continue to do so. By doing so, your filtration rate obviously goes down, and so now your creatinine's shot up because it's trying to get everything out. So your kidneys will continue to work harder with that. So with that being said, what they do with those patients, they usually take them sometimes to hemodialysis, put in a temporary line, filter, clean out their blood, and they flush them. They load them up with IV fluids. So they do almost like the sepsis protocol where they do like 30 ml per kilogram, they load them up. Just because you want to flush those kidneys and get as much fluid in there as possible in order to hopefully open it back up to get that out. If not, then you can go to dialysis and have to get that filtered out. Because if not, then you can just shut them down completely. So, and then you go to chronic glomerular nephritis. Now, the big thing with that is proteinuria, so you're gonna notice a lot more protein in your urine with that, so a lot more protein dumping. But also you're gonna notice a lot of hematuria with those patients. So just be mindful of that. Sometimes this may not even be enough that you can actually see it, so it'd be more microscopic, but you can actually, when you actually do your studies, whether it be a UA, creatinine clearance, and just different things, those will actually, it'll be listed in there, like actually how much blood. So one thing too, as far as your diagnostic tests and different things that you can do, besides like the CTs, MRIs, KUB, is your urine studies was a big one. Like you'll have a lot of 24-hour urines that you'll have to do. You discard the first urine that you do, and then you start from there, and you collect it, and you keep it on ice for the full 24 hours, and you take it. You do get those specimens or those containers from lab, whether you're at home and or here. You keep those on ice, and you pee, you place them into place your specimen in that, and then you bring the whole jug back into them, and then you test and everything, how much you've put out from that time. Also, you've got kidney biopsies is a big thing, as a percutaneous renal biopsy. So make sure that you're, the big thing whenever you're doing those is just kind of stabilizing up the kidneys and just keeping the patient still. That way you don't nick anything. And then.
Do you do that from the back?
Yes. And it's almost like, have you seen a nephrostomy tube? Like the percutaneous nephrostomy tube is essentially right there. It's where you'll see them. Yeah, that's where they'll go in. So usually the patient is laying on their stomach when they're down, like they'll usually send them to IR. They'll be flat on their stomach with their arms and everything elevated. They kind of elevate it, bring it up, hopefully expand it out so the ribs and everything are all up and out of the way. And then they get the ultrasound and they mark it and they go right from the back. And then you go to, let's see, chronic glomerular nephritis. No, we already talked about that. Chronic renal failure is the next one. The big one with that is usually seen in more than 75% of this. Well, they're considered chronic renal failure when they've had at least 75% damage of their filtration rate. When they get 75%, anything above that, that's when they're considered chronic at that point for a while. That's the big indicator, or the big difference, the big mark on that one. Not always the most, how to determine if it's more of acute or a chronic condition. Lower UTIs, that one's kind of a given regarding UTIs. Now, obviously, some patients, depending on age, will not show the same symptoms. Obviously, if you're older, your change in LOC is going to be your biggest indicator. But that's obviously younger. Assess the patient, assess, whether it be sexual habits, could even be bathtubs, especially for women. Make sure your bathtub is really clean before you take a bath, or after you take a bath. And then just you got your antibiotics. And it depends on if it's bladder spasms or what. They do give Peridium. Please remember that one, or you may hear her talk about that one. Peridium, it is an antispasmodic dealing with the kidney pain. It does do really good, however, it stains everything. It will give the color a orange discoloration, and it will stain everything. So just let them know, wear ye not so good granny panties or whatever you want to do, because if you leak or have any type of stress incontinence or whatever, you're going to leak and it's going to stain everything you've got. Also, as far as you promote, just to be aware too, it will stain the inside of the bowl a little bit, because it will actually, it's not pleasant, but it works. It does really good though. And then you got nephrotic syndrome, also marked by proteinuria, hypoalbuminemia, hyperlipidemia, and edema. Is the big thing with nephrotic syndrome that you're looking at. Now, the dominant clinical features are individuals who have nephrotic syndrome. The big thing with that is mild to severe dependent edema in the ankles and the sacrum, periorbital edema. That's going to be your big your physical assessment findings on those particular patients that you're looking at. Their urine is going to be very foamy, so whenever they pee, it's going to have like a little bubbles and everything at the top, so a lot of froth.
You're ruining my coffee for me. Don't say that.
As long as it don't smell like pee, I think you'll be okay. And if you do that, we'll think we got other issues going on. It's like, why do you smell like urine over? And then from there, also, in their urine, they're going to put off a lot of fat and a lot of fatty bodies and everything too that they'll actually pee out. So little fat deposits. So increased fatty cast and oval fat bodies in the urine. Big thing with those particular patients, because it's marked by proteinuria, so we're dumping all that protein, so you need to increase their protein intake. So protein replacement with nutritional diet of 1 gram of protein per kilo of the body weight. With that. And of course, with this one, yes, you do want to restrict the sodium, and of course diuretics if they have a lot of edema in those key locations. Then neurogenic bladder, although I know a lot of people probably heard a lot about that one though. Basically, it's a dysfunction caused by the interruption, basically. I can't pee right, plain and simple. It ain't normal, it ain't worked right, I don't know what's going on with it, is what they'll say. I ain't peed right in 2 years, so Like I said, I had some neurogenic bladder, I don't know if it's nervous or what, but, I mean, that's what, yeah. So it's a dysfunction caused by the interruption of normal bladder function. Basically, with those, it'll be a lot of spasms. But your biggest thing is also bradycardia, headaches, and severe hypertension. And then, of course, the infamous renal calculus, or your stones. Okay. With the stones, your biggest thing with those are, honestly, it depends on what kind of stone it is. So if you can pass it, that's great. About 80–90% of the stones are normal. They are able to be passed. However, there are some that's too big that has to be broken up and everything, and then for you to actually go have them removed, or if lithotripsy doesn't take care of it as well. And of course, as you remember too, I don't know if we talked about it, but there's different forms of each of those stones. There's also those called staghorns. They look like they've got horns on them, and those are a lot more painful because you'll have a lot more hematuria, because essentially as the stone comes down through the uterus and going passing through everything, it rips and it tears the entire way all the way down because it's tearing through. So you'll have a lot more blood, and it's a lot more painful. So a lot more pain medication. So very nice. Yes. I've only had one, and I named him Lucifer. He was the devil. I took 24 milligrams of morphine, and I was like, still like, I'm dying. Then I finally passed him. It felt like I was passing the Buick through a water hose. And then I relaxed, and the morphine hit, and I went to sleep. I felt like I slept forever. So, but yeah, so they're very painful, very discomforting, and you can feel them moving too. Like you can feel them kind of shifting and working. And I was like, oh God, here we go. No, yeah, yeah. Good times. But they are very, very discomforting though. Yeah. So the big things or the fun facts with this, I do wanted to make sure, dealing with like the 24-hour urines, if you have a patient with a 24-hour creatinine clearance, those patients, or if you are the patient, encourage them not to eat excessive amounts of meat before they start the diet. Because once you eat the meat, obviously the creatinine put it off into the bloodstream, your body's going to excrete all of that, but it will give a false positive actually of what you're actually putting out. So, also if they're immobility due to a spinal cord injury or other disorders, it allows calcium to be released into the circulatory system. So this is more off of your parathyroids, released into the circulatory system, eventually getting filtered through the kidneys, which can cause an increased amount of that renal calculi. So keeping those patients moved, turned, hydrated, whether it be oral and or IV. So just making sure of those if they're in mobility. But the memory joggers that I want to kind of help with, the three I's of neurogenic bladder, when you're actually dealing with that dysfunction of the interruption of normal flow, you've got incontinent, initiation changes or in the interruption, and inability to empty the bladder. So I'm pissing myself, I can't piss at all, or it's just fucked up. That's the layman's terms, essentially. But the three I's though are incontinent, initiation, and inability.
I like yours better.
You will remember that version on the test.
Yeah.
Yeah. So, pissing myself fucking won't work. Yeah. What the hell? Yeah. So, those are the big things with that. So, like I said, let's see, regarding hers. UTIs, considerations for the older adult, the big thing is if they're obviously older, loss of cortical tissue and nephrons basically lead to inability to filter blood and or excrete waste, so obviously it's decreased. So just be mindful of that. Hydration status, which we already kind of talked about. Nocturia, getting up more at night. Obviously they're gonna be at higher fall risk. And then dealing with your GFR, you're already going to decrease with age anyway. So just please be mindful of that, because usually by the age of 65, you're doing about 65 ml half an hour as far as the rate for a young adult. But it increases the risk for fluid overload is the big thing. And already, if you're already diabetic, hypertensive, or heart failure, you're already at a higher risk anyway of those, and already you're at an age to the decreasing of the GFR. So, let's see. It's funny. Dry vaginal tissue. Well, that means they didn't get an oral or urethral actually. That's a slobber down. Alright. Let's see, physical assessments. We done talked about the skin discolorations. One thing that I forgot to put on here, and I just thought about it, and it's not even on here, and if it is, I don't see it. Patients who are in renal failure, you may see them with a white cast on their skin, so to speak. Look like frost. So it's a uremic frost as far as. So this is basically built up of that. So where you're unable to excrete it, it's going to come out your skin pores.
Are they gonna stink?
Some can, it depends on how long, let's just say they miss like
How
a
long
week of
they've been there.
dialysis.
Yeah.
You're gonna come in, you're gonna say they're jaundiced, their toxins are trying to excrete off in their
Everything's
skin.
coming out there.
So everything they put in their body is trying to come out, and it's not gonna smell good.
It's gonna come out somewhere.
Yeah.
If it ain't coming out as far as the normal way, it's gonna come out one way, and that's how it usually comes out, is up by the skin. So it'll come out your pores, and you'll have like a white hazy frost, like you've been outside and grass, it's all white and frosty. Yeah. So that's what your skin will actually look like, and it's the uremic frost.
I've only ever seen that like 2 times, but they didn't come for like 2.5 weeks.
Okay.
Yeah.
Yeah.
Had 20-something kilos of fluid on and couldn't breathe.
Oh my gosh.
That'll do it.
Huh?
Did you say 20 kilos?
Yeah. There's some people that they just don't
They
care.
just don't care about their health. There's some
They don't
people
care.
that don't care.
And you can only pull so much.
Yeah. Now, as far as a cysto, though, one of the things you want to look at that. Basically, it's a cysto is basically going in visual imagery, looking at the bladder, urethra, lower portions of the uterus, kind of see what's going on. Okay. The actual cystoscopy of it. Going through the urethra, unless you got another way to get in there. Until you get in there, usually the urologist is sterile, obviously. It's done in OR, your MPO, you're put under. It's not going to be pleasant, but some people get into the rod, so you're going to actually enjoy that. Big thing to watch with those patients, it's real, and you will see it. That's why I say you'd be surprised if people stuff anything up any orifice. Obviously, after surgery, obviously you're going to watch their ABCs. That's with everything. Changing the vital signs, including the temperature, is going to be the big thing. Obviously, changing their urinary output, especially after a cysto. Because sometimes they go in, they actually do a stent placement, cysto with stent. They go in, open it up, and it leaves everything to drain. So, say that they go in, say that your patient's got their right kidney, and they've got a stricture in between the kidney and the bladder in that uterus, and basically they go in, they do a cysto with stent, they go in, and you notice an increase in their output afterwards. That's to be expected because everything now on that side has been just built up into the kidney and not draining, so now it's going to drain down. Now, it is to be expected and do notice that you will have some hematuria and everything like that afterwards, just because of the surgical procedure of actually going in and actually opening that up. Okay. I had a patient, before I switched over to the Roman now, she ended up having a lot of flank pain. She came in, had right flank pain, decreased urinary output, and right-sided, right lower quadrant abdominal pain. So it wasn't her appendix, so they did ultrasound and everything on her, showed her that she had looked like air or just a buildup of fluid, so they didn't know exactly what it was in that right lower quadrant. Well, they said, all right, we're gonna do a cysto because you're not peeing right, so we're gonna go and do a cysto, possibly a stent if that's what it is, and maybe like a stricture. So, because when they done the CT with the dye, when they took the visual imagery, they couldn't see it come from the kidneys on down. Like, all right, so we got a stricture, we're gonna put a stent in. They went to the left, they went to the left when they was that, so it was on the right, and basically, once they popped through, there was no uterus. So somehow it was not connected, and everything that was coming out of her right kidney was draining into her peritoneal cavity. So that's what that fluid collection and everything was. So with that, what they have to do is urinary diversion. They do a nephrostomy tube. They put in a percutaneous, or PC in a percutaneous nephrostomy tube. Basically straight from the kidneys, comes straight out. You'll see the little tube, thing in the hooked to the back. She had other issues, but I mean, that was the reason for that. So that was the reason for the abdominal pain, because that extra fluid collection was pushing and hitting right at those certain nerves. It was causing that, slight distension, causing the pain. Wasn't right, but she's still able to do her daily activity of living. But that also explained why she wasn't producing as much urine, because everything was just kind of going into her peritoneal cavity at that point. So just be mindful and looking at that. So always knowing how much they do even at home as far as knowing their baseline, to know where they're at. So
She didn't have any altered levels of consciousness, like she was still.
she was completely alert, yeah. Biopsies, let's see, informed consent, obviously you have to be NPO. Same thing where since you are dealing with the kidneys and you're getting near the adrenal, very vascular, so just monitor for bleeding. Same thing with you do with the liver. Big thing is just monitoring for H&H, like what we talked about already. Sometimes they do put a actual pressure dressing on those particular entrance sites when they actually do the renal biopsy, and they have to be on bed rest. Sometimes depends on the patient as far as the bleeding risk and or medications and or the clotting factors. Be for about 2 to 6 hours usually, and they'll have they'll lay on the affected side for up to an hour. So like liver, since it is more vascular, it's 2 hours. If you're doing just renal, you got up to 1. Now, one thing, if you are suspecting a bleed, if you notice that you're at the nurse's station, you see that your patient who just had a renal biopsy's heart rate has went up, their blood pressure is going down, so which is a sign of what?
Hemorrhaging.
Or what, sorry?
Hemorrhaging.
Okay. The way it said it wasn't synced up, I think, well, yeah. So you got a hemorrhage, and so you got some blood loss. Well, if you go in, you don't see any blood, what are you thinking?
Syndrome.
So what are some other things that you can see or potentially assess with that, or that you would know?
Bruising.
Okay.
Edema.
Okay. Some units, especially if it's like in the ICU where they, where you're watching your urinary output hourly, you'll notice a change in that too, because all that pressure is putting on that, therefore obstructing from more outflow to come out. And just being mindful of, of course, the hypovolemia. So then you're at hypovolemic shock and, other things you have to watch out for. So like you said, the bruising, the big thing, you'll end up having that all the way around the flank area. So now, what is one physical sign that you'll see on the skin if you are having some type of internal bleed? What is it called? What's it look like?
It's gonna be like purple.
Okay, but like what's actually, like you got little specks of it. What's it called? Petechia. Yeah. So you'll notice that on like underneath the skin, like it'll essentially start coming up. So. All right. Nurse is monitoring a client who had a kidney biopsy for post-operative complications. Which of the following complications should the nurse identify as causing the greatest risk for the client? just say infection, hemorrhage, hematuria, or pain.
What was the choices there?
Wait,
Sorry.
I didn't hear the
What's
question.
the question
A
again?
nurse is monitoring a client who had a kidney biopsy post-operative for complications. Which of the following complications should the nurse identify as the greatest risk for the client?
Immaterial.
Infection, hemorrhage, hematuria, or pain?
Hemorrhage.
Hemorrhage, yeah. Hemorrhage is the greatest risk following kidney is due to lack of clotting with pressure to the site. So that's why sometimes you'll notice that pressure dressing. With those pressure dressings, you don't want to leave those on too long though, because it can cause some serious issues. Speaking of pressure dressings, especially whenever you get to cardiac next semester, there was a time that a patient had a heart cath, had a pressure dressing in the femoral. They didn't take the pressure dressing off the way they should have. They left it on majority of the night. The person lost a leg. All because of that. So, that was the quick cliff note version for you. But yeah. A nurse is reviewing the results of a client's UA. They indicate the urine is positive for leukocytes and nitrates. Which of the following actions should the nurse take? Repeat the test early in the morning. Start a 24-hour urine. Obtain a clean catch urine specimen for culture and sensitivity. Insert a dwelling catheter and collect a urine specimen.
C.
Clean catch and for a culture and sensitivity. So a clean catch is going to be your best bet, honestly, and or a straight cath in order to receive it actually from that. So if you work in a facility and that you also get a flowing catheter from another facility, it's usually the best practice to go ahead and get order, of course. Taking out the Foley, put it in clean and sterile, you know, the way you're supposed to, and then obtain a urine off of that. Because sometimes if the Foley's been in there very long, then therefore bacteria can grow on the inside of the actual catheter and or the tube, and then you can actually give you a false clotting. So the only time that you can get urine from a Foley bag is when you first put it in only. Other than that, you have to draw it from the actual side or you have to get a whole new one in. So, but never draw it from the actual bag itself whenever you do have a patient with that. Cystitis, basically just inflammatory issue to the bladder, could be related to infection, basically, in which you would just treat with antibiotics. Depends on what they're allergic to or not. Could come from a few different other issues, whether it be like cancer related to gynecologic regarding females, pelvic inflammatory disorders, Crohn's disease, diverticulitis, those kind of things. Infection, basically UTI, most common output. The most common UTI is about 80%. It's just caused by what? What kind of bacteria?
E. coli.
Not wiping it properly could be basically a big part of it. Yep. So always be mindful of that. It can lead to pyelonephritis, inflammation of the parenchyma collecting systems essentially, and can lead to urosepsis. Okay, so just be mindful of that. Expected findings. Talked about that. That's fine. Good. Just making sure to run through and make sure there's anything else we need to. Renal calculi. Patient with stones, you usually go ahead and give the patient a strainer as well for them to pee in, or for them to have in the room. Especially if it's a female, give them a hat for them to pee in, and then they can, once they get up, then they can pour the urine in through the strainer to see if they actually get the stone. Once they pass the stone, you can send off the stone for the actual sampling of itself to see exactly what it's what it's made of, whether it be calcium, phosphorus, magnesium, whatever. That way you can actually make your dietary modifications as far as your lifestyle, as far as depending on what it is. So, what endocrine system would put you at a higher risk for renal calculi?
Hyperparathyroidism.
Yep, because the parathyroid is contributing to the calcium as far as the, very good. Straining the urine, usually it says increased oral intake to 3 liters a day, that's a lot of fluid. Maybe we just give us some fluids and encourage ambulation, of course. One thing that, as far as, because it's always, you'll see a lot of like, oh, avoid NSAIDs, avoid NSAIDs. This one you can give, but it's also Toradol. And ketaboric is the name for it. You can give that one, it is IV. It's essentially a Motrin on steroids, is what I say. Is what I've always believed it is. It's still an NSAID though.
For pain?
For the discomfort related to the renal calculi. So, it actually does really good. You can only give, I think it's 30 milligram IM, the IV. And if you, 60, everything else has to be IM. So it's not too much. Education. Obviously, if it is, increased calcium, if it's a calcium base, and obviously limit your calcium oxalate. So like even your Tums and things like that, as far as medication, try to avoid those. Avoid sources such as like spinach, black tea, rhubarb, cocoa, and things like that, and avoid and limit sodium intake. Uric acid, such as organ meats, poultry, and red wine. So now with uric acid, you want to when you have the increased levels of uric acid, what medication is given for that? Allopurinol. Usually like for the gout, you don't have that like your uric acid will go to the joints and very painful and everything. So they do to decrease that. Allopurinol prevents the formation of uric acid, so it does really good. Urosepsis, basically stones when UTIs, goes to the bloodstream. Essentially, basically, when it's left untreated, it went into the circulatory system, and now we're having to deal with the after effects of it. So, any type of sepsis in general, usually sometimes infection, your heart rate's going to be up, your blood pressure's going to start going down, like you're going to have the fever and the other things. So, anytime that you are suspected of having any form of sepsis, go ahead and it's best you always get your blood cultures, everything first, 2 different sites before you even do your antibiotic. So if you've got, or if you've got a patient that has came in and they've already got antibiotics and then they got blood cultures, then it's not going to really contain you much at that point. And then you've got BPH, as we talked about, that benign prostatic hyperplasia. Basically, this is your prostate swollen, and it's restricting your urine flow. So, in male patients, you don't have one. So, of those, basically, it's a roto-rooter is what we call it. It's a TURP. You go in, roto-rooter, they'll bore it out. They'll put in a very large bore 3-way Foley catheter. On those patients, you'll see a continuous bladder irrigation. Now with that, whenever you do have those patients, you have to hand dial with the dial flow on the actual line in order to control the flow rate, because you want to essentially, the doctor will give you usual orders, but you want to go more and you stay around like a peach to a clear is where you want to be in order. So at first you're going to have to go at a much higher rate. So you're going to go through those bags pretty quickly. And those are 3,000 liter bags. So, like, you'll have two going, you'll have two, one spiked and one ready to go. One's going, once it's done, clamp it off, and open this other one up to get what you need, because you need to keep that going. Because if not, your Foley can clot off and then it's a mess. Because, it won't drain, because your body is having to heal, but it's not gonna heal if it's full of urine in there all the time. So you have to wash out the clots and everything so it can come out. But if not, then you have to revert to either hand irrigation to try to get it, unclogged, and or potentially get the urologist to come back in and say, hey, it's clotted, we cannot get it unstuck. We've either gotta take this Foley out and have to put a new one in, and then sometimes those are actually put in an OR, and it's kind of difficult because of everything, because it's very painful, and then because of the surgery. So more bleeding trauma and everything else.
Are those patients on the floor, or they're not ICU? Okay.
Those are on the floor. So that's why it's so, cautious that whenever you're taking care of, if you've had somebody that's got CBI, it's making sure you're keeping an eye on that Foley. So, you're doing minimum every 30 minutes to an hour for your urinary outputs, just to kind of keep that back, because if not, it can build up quick, especially depending on how many clots and how fresh it is. So, but with those, you want to do a high-fat, protein, high-fat, protein, carb, low-fiber diet on those particular patients. And then common, for patients who have BPH, where you're not able to pee, what do you think some symptoms would be? Feel the urgency. So you got increased urgency to go, inability to empty. Here's your 3 I's. So incomplete empty bladder, obviously you'll like the dribbling, or you'll like hear them sometimes, like if you hear them pee when you're walking to the bathroom, you'll hear like pulsating, like it'll pee, go. It's just because that prostate is so swollen that they're trying to force, trying to get that urine out. So also sometimes with that, watch those patients, because when they try to go into pee, when they're pushing, they can hit that vagal nerve. Same thing as when they're going to the bathroom to use the bathroom for bowel movement. Make sure they don't vagal down on you and then have to pick them up out of the floor. Obviously, patients who have BPH, they're at a higher risk for what? Urinary tract infections. We're due to the inability to empty. Therefore, the body is very warm, so it's just kind of sitting there cooking. So you're at a higher risk of for infection. So, even though urine is sterile, renal cancer. Let's see. Kidney tumors classified into 4 complications: meds, hereditary, tobacco. Nephrectomy, we already talked about that. As far as the removal of, watch for hemorrhage, watch. No, okay, that was in on that one. All of that was. Renal, that was what, 1? Yeah. Let's see what she's got for renal too, PowerPoint. Must be like your dialysis and everything too. Just to make sure. Hopefully I'm not boring y'all. If not, oh well, we got it. We're not on the floor. Yep, there's your acute tubular necrosis regarding what I was talking about. Most common cause in hospitalized patients, ischemia, nephrotoxins, or sepsis, which is what's caused usually from the rhabdo from the fall. So, build up of that myoglobin. Phases of acute kidney injury, there's onset, oliguria, diuresis, and recovery. Hypertension, weight, cortisol, parenteral protein, this is